Hello everyone, my name is Mary Catherine Waddell. I'm here today to tell you about the unique, little-known phenomenon of the yips and its significance in the lives of many performers and athletes. I will give you a brief overview of a definition and what the yips means in the lives of those who suffer from it. Then I will introduce the two proposed subtypes and explain their classifications. Furthermore, the mechanisms and physiology of the continuum these subtypes fall on will be discussed, followed by the treatments and outlooks associated with them. The yips is a multi-etiological phenomenon that is characterized by lost or abnormal movements during the execution of fine motor skills in performers engaging coordinated and complex body movements. This psycho-neuromuscular impediment is exaggerated by pressure and anxiety and results in compromised performance in sports. This condition has often been reported in specific sports which require well-learned precise skills, such as golf, baseball, bowling, archery, and darts. The term yips comes from golf, where it was first used to refer to an affliction that can cause even the best golfers to miss short putts. The yips have affected many professional performers and even forced early retirement in severe cases, such as professional golfer Tommy Moore, who coined the term yips, New York Yankees second baseman Chuck NeBlock, and New York Mets catcher Mackey Sasser. Prevalence rates in participants of previous research, which is unfortunately minimal, range between 16 and 54%. These values were taken mostly from low sample size case studies, in which the number of studies currently published are less than 20. Different subtypes of the yips were described on a continuum between type 1, task-specific focal dystonia-related symptoms, and type 2, symptoms related to performance anxiety or choking. Where on the continuum the Yips phenomenon sits remains a matter of debate. Much of emerging research focused on understanding the physiology of the Yips, which is little understood by all literature to date, with no known treatment. The Yips have characteristics of task specificity and involuntary movements, in which the symptoms occur during a practice task requiring the execution of repetitive fine motor coordinated movements under high pressure conditions. Task-specific focal dystonia is characterized by abnormal motor activation during the performance of specific repetitive motor tasks in one body region, such as the face, neck, or a single limb. The two share common pathogenic mechanisms, and although little understood, the common proposed mechanisms to explain the yips in conjunction with task-specific focal dystonias are abnormal inhibitory mechanisms, abnormal motor preparation and sensory motor integration, and abnormal neural plasticity. First, abnormal inhibitory mechanisms at different levels of the sensory motor system were common in studies of all patients with forms of focal dystonia, suggesting that this is a fundamental problem in its genesis. The motor system uses a variety of forms of inhibition to control the precision and smoothness of movement, including reciprocal inhibition at the peripheral level and surround inhibition at the central level. Reciprocal inhibition allows for control of muscles around a single joint through coordinated contraction and relaxation of agonist and antagonist muscles, respectively, and a lack of reciprocal inhibition can lead to the simultaneous activation of both, known as co-contraction. For example, one study examined individuated finger movement of the hand required selective and specific activation of muscles moving the intended fingers and inhibition of uninvolved ones. They found that in focal hand dystonia, abnormally prolonged muscle firing and co-contraction with overflow of activation of inappropriate muscles led to dystonic posture and impaired motor control. This was also observed by a study in 2018 in which co-contraction was apparent in yips-affected golfers. Next, surround inhibition at the central level is selective recruitment and activation of muscles for a particular task with simultaneous inhibition of surrounding muscles that are necessary. This is further explained in the following section of abnormal sensory motor integration, but overall, the lack of inhibition at multiple levels could explain the unintended activation of muscles and resulting abnormal motor activity in patients with task-specific dystonia. The remarkable characteristic of task specificity, when symptoms manifest only during the affected task, suggested a deficiency at the level of the organization of established motor programs at the central level, as mentioned above, and not simply movement. Normally, precise motor movements are accurately planned at the premotor area and relayed to the motor cortex to be undertaken. Abnormal movement preparation and defective motor programming may be a result of underactivity of motor areas important for movement preparation during the specific task compared to normal controls. Those high-level motor regions coherently organize bodily sensations and motor responses for the preparation and control of complex movements, which is known as sensory-motor integration. So with over-practice and over-repetition of motor tasks or excessive sensory stimulation, abnormalities in the sensory-motor loop have been found with the saturation of motor commands by altered sensory representation. Thus, abnormalities in the sensory-motor integration resulted in dystonic symptoms. But this is further understood by the loss of cerebellar influence on the sensory-motor cortex in abnormal neural plasticity and abnormalities within the basal ganglia. Task-specific dystonias are often associated with abnormal plasticity, causing repetitive motor activities to abnormally lower stimulus threshold for activation of a specific motor circuit and change the sensory-motor complex. Typically, neuroplasticity involves the ability of the brain to reorganize its neural pathways as a function of both internal and external stimuli. So a typical excitability activity could result in the deterioration of communication pathways between the central nervous system and the periphery. And abnormalities in the basal ganglia, which modulates surround inhibition, was produced by abnormal synchronization of presynaptic inputs to antagonist motor units, most likely through abnormal inhibitory integration of afferent inputs from adjacent body parts. The possibility suggested of underlying basal ganglia network abnormality was observed by a study this year when a reoccurrence of the same symptoms after 5 years of interruption of the particular task. The author further found that these networks can be reactivated on exposure to the same task. Other studies supported this hypothesis that the abnormal network can be deactivated on stopping that particular task, possibly due to sensory motor returning. Moreover, another study this year found that the abnormal afferent inputs from the cerebellum to the basal ganglia could induce this excessive sensory motor cortex plasticity. Thus, unconstrained plasticity may explain why over time, repetitive overuse leads to uncontrolled reorganization of sensory motor maps and the eventual development of dystonic symptoms, which can impact one's livelihood, particularly if symptoms are severe. Unfortunately, athletes with possible task-specific dystonias have received little research attention. Type 2 Yips was described to have a psychological origin, less related to our course. However, it's important to recognize a psychological component of this condition that contributes to the motor phenomenology. If the athlete remained in possession of the motor program for a skill, but was temporarily prevented from accessing it, this was supported the notion that the disorder is psychological, type 2 Yips, rather than a physical skill-based problem, type 1 Yips, reported by a study in 2018. Another study showed that the Yip-affected athletes were more likely to be perfectionistic and engage in more rumination and reinvestment, as well as more concerned about making mistakes and doubt their actions while performing the affected task. The literature reported many qualitative accounts supporting choking as a psychological component of the Yips. Furthermore, it was recently found that the Yips are not caused by anxiety factors but can be affected by them. So overall, the Yips and choking can present a significant failure of motor performance due to excessive mental pressure and associated with it self-consciousness, anxiety, and reinvestment. And reinvestment just means a tendency to consciously control well-learned skills under pressure. So this experiential loss of emotional, cognitive, and physical control was prevalent within many sports, and it may be triggered and exacerbated by the pressure to perform, particularly from coaches, and performance anxiety in both training and competition contexts. No systematic review has been published with regard to effective management for Yips-affected athletes, but various recommendations have been proposed, mostly with anecdotal evidence. First, cognitive methods such as pre-performance routines, positive self-talk, talk therapies, and music listening are all forms of relaxation distraction techniques to guide Yips-affected athletes away from this self-attention. Solution-focused motor imagery has been used to guide and facilitate vivid images of performance without Yips symptoms, but it might also make athletes more self-conscious about their motor outputs and exacerbate type 2 Yips symptoms. Sensory motor tricks, such as changing grip and retraining, may hold promise for pathology associated with abnormal motor excitability and sensory motor integration. Other oral medications of muscle relaxants have been proposed to alleviate motor symptoms as a result of sensory symptoms that result in the overflow of stimulated muscles not intended in the desired movement. Even acupuncture has been tested because it engages anxiety-reducing mechanisms involving serotonin and noradrenaline. The most widely used method to specifically treat type 1 yips has been botulinum toxin injections. However, many cases reported subsequent muscle weaknesses in that area, reducing the muscle's threshold to return to original strength and function. The diverse range of treatment options might imply the absence of definitive interventions because overall, there is no conclusive evidence about the effectiveness of any treatment strategies for yips-affected athletes. The ability to correctly perform movements in everyday life is critical to adequately interact with the environment. And understanding these exact etiologies is crucial because there's a clinical need for the classification system to guide diagnosis and treatment and organize current knowledge regarding these biological systems. The challenge is connecting the growing understanding of etiology and how these mechanisms relate to varied phenotypes. But current etiological classifications provide only limited guidance for recognizing syndromes. Bridging the gap between phenomenology and biological mechanism has been the universal focus for guiding future scientific research because this remains highly contradictory. The yips is a difficult and puzzling condition for athletes, coaches, and health-related professionals, and formal scientific research is needed to further discovery of effective treatment and management. Thank you for coming to my presentation today.